Good to have you all join us again today. Today's topic is reinvention for social distancing, adapting operations and new digital health developments. Loads and loads to talk about in there, and I'm delighted we've been joined today by, or we are being joined by, two real experts on that topic. First of all, Sharon Lam, who's a partner at one of our legal firm members, McDermott Will Emery. And secondly, Nick Stevens, who's executive chairman of the RSA Group, as well as being a non-exec at a number of biotech companies. So some fantastic experts will be joining us a bit later on in the webinar to talk about innovation and what this pandemic might mean for us as an industry. But before that, as ever, I'm going to introduce Steve to go through the news of the week. Just before I do that, as ever, like to make this as interactive as we possibly can be. So do please fire in some questions. We've got a couple of polls to get the discussion going on social distancing and the new guidance that's come out. But do have a think about questions that you might want to put to Sharon and Nick and possibly Steve as well, thinking about the implications of COVID for digital healthcare and how we adapt operations in the future. And we'll pick those up a bit later on in the discussion. So that's the first thing. Secondly, my colleagues in the comms team always remind me to ask you to do please tweet about this webinar, hashtag BIA webinar. Shannon and our comms team will be doing that. And if you've got any views or things to share, do get involved on Twitter as well. Okay, I think that's it in terms of introduction. Steve, morning.
Morning, Michael. Shall we go through the news?
Yeah, absolutely. My big challenge this week, Steve, is to try and get the slides to advance at the speed at which you're talking, which I singularly have failed to do on previous weeks, but I'll give it my best shot. Yeah, so it's been a massive week. Let's just go through the agenda first, so I don't get the slides completely wrong on that front. See if I can get them to move forward.
Well, you can see it's the last time I wore a tie for a while, isn't it, on this opening slide? It feels like a long time, and you can see how long my hair's got in comparison as well.
So, I know. Yeah. Okay, so there's the agenda. Here's the latest developments. And so it's been a massive week, Steve, both in terms of kind of big guidance releases, technology developments, big news. So let's just try and kind of quickly dance through that. So the first thing to talk about is really that plan to rebuild that the government released in stages, beginning with a series of trails, and then the Prime Minister's addressed the nation. The biggest audience since Charles and Diana's wedding, I think, is what I read. So clearly a lot of people tuned in. But what about the content then?
Yes, I'm not sure it was as exciting as the Charles and Diana wedding, or perhaps the '66 World Cup final, and perhaps a bit of an anticlimax in terms of what people were led to believe. But I think you saw the Prime Minister's speech on Sunday, then the formal document. This is the 50-page document that came out on Monday, and then discussion of it in the House of Commons. So it did lead up to a sort of a sense to have a start about the partial reopening of the economy, where it's really focused on, we're through the peak, what we're going to do next, and set out some interesting things. I think what was interesting for me was, if you looked into it, there was quite a lot in it about the sector, what the government's intention was, that they are focused on making sure we've got sufficient access to essential medicines, PPE, testing equipment, vaccines and treatments. Picked up the Vaccines and Treatments Task Force, which will accelerate the development of vaccines and treatments and ensure if one becomes available, it can be produced in mass quantities. Very important for our sector. Many members are involved in thinking and processes behind that. And it was nice that they gave us a name check in the overall thing as well. So I think we'll talk a little bit about some of the other elements, but it's interesting to see that the life science sector is at the heart of the government's overall strategy to rebuild the economy, get us up and working again, and getting us out. And I think we'll talk about some of those details as we go through.
Yes, and talking about kind of getting us back up and running again, one of the big issues that people were looking for clarification on is something that you've suggested we run a quick poll on, isn't it? And that's the wearing of face masks. So we thought we'd do a quick poll. Here's the graphic from the little graphic from the government's handy guide to making your own DIY face mask. I must admit I haven't tried my sewing skills on it just yet. I don't know whether you have, Steve, but maybe that's a challenge for the weekend. But here's the question, which I'll load up. Do you want to read it out while I get the system to load?
So obviously some of this is about social change, and we're talking about how do we adapt today. So we thought we'd find out, the government's new guidance advises people to consider wearing face coverings in enclosed public spaces such as shops, trains and buses to help reduce the spread of coronavirus. We're thinking, where are you in terms of your current or planned behaviour? You can be planned behaviour if you've not left the house yet, current behaviour if you've been out and about this week. Are you wearing a face covering at all times and not at home? Do you wear it in enclosed public spaces? If specifically required to do so, you're not wearing one at the moment, or you don't know yet. Quite one of those interesting things, I think, which is almost a cultural question, because we're not used to this in the UK, but obviously we can see that there may be benefits, certainly to others, if we use face masks. And I'm just interested where we are as a community on this one. So do please give us a sense as to where you're at, and no social isolation on this one, because everyone gets to vote in a poll. How are we doing? Have we got a good spread there? People engaged.
Yeah, got about 2/3 of people voted. Let's close it now, I think. And I shall share.
I genuinely have no idea where this one will come out, so let's see.
There you go.
Yeah, is that what? So people are thinking. Most people are thinking about it. That's quite interesting, isn't it? And would do it if they had to, if they were required to do so.
Yeah. It's an interesting one, isn't it, Steve? Because I mean, we talk about. I put this line about requirement in. I mean, for instance, in London, they're saying you really need to wear one on public transport. But actually, there's nothing, as I see it, in the legislation that's going to force people to do that, is there? I don't know. It's a delicate balance between sort of where we kind of come down in terms of requirement versus sort of, kind of social pressure, that kind of thing. It's going to be interesting to see how it plays out.
Yeah, no, let's keep going. Thank you for that. Interesting to see. So,
okay. Sorry, go on.
A few other bits that are around this week. Those of you who follow the research side of things, new IMI projects on coronavirus came out this week. Interesting to see that there was significant UK involvement in that, too, led by UK organisations. So although we've left the European Union and the future relationship is open for discussion, interesting to see significant continued partnership with UK, a significant presence in coronavirus projects at a European level. Again, more developments, I think, of interesting stuff with the Genomics England capability, who are going to sequence 20,000 people and look at that with mild symptoms to see what affects some people more than others. Again, really interesting to see the UK do some really interesting science on COVID-19 based on the platforms that we've got within the ecosystem, which I think will really add to the scientific knowledge and potential opportunity for companies to build on these things. And obviously many people are involved in that one. Much heralded in some of the newspapers this morning, we are seeing the first antibody test kit be granted Public Health England clearance, paving the way for NHS testing on a national scale of antibody testing. Quite a show on that this week. And obviously we were at a position a few weeks ago where many of the antibody tests hadn't reached the standards the MHRA were requiring. It's good to see that the Roche one is there, and I expect to see some others there in the very near future. But it does mean that testing has moved on a bit. I suppose the challenge there is it's a serology test, and you need a significant amount of blood from individuals. So the question as to whether that's as easy as a pregnancy test or other things still remains. And I think the scaling challenge of that and how that operates in it's still ahead, but it's good to see that there's breakthroughs there.
Yeah, absolutely. So let's just go back to the guidance for a second, Steve. So the workplace guidance. So kind of following on from the Prime Minister's stuff, there was the BEIS guidance that was issued on working safely, something that we fed into from an industry perspective. We were consulted on this, and specifically we got kind of inclusion of the lab and research facilities guidance in there, didn't we?
Yeah, I mean, I think as with all of these things, there were guidances in several different types of working outdoors, working indoors, stuff for offices, stuff for particularly for labs and researchers, depending on your business. You should look up and have a look at it on the gov.uk website. Probably it leads to many questions. It's non-statutory. It doesn't supersede any legal obligations, but I suppose it provides some thoughts and questions and some processes that people should engage with. And I think many labs and research facilities, as these webinars have shown, have continued to run, imposing new ways of working, whether that be distance, whether that be shift patterns, A/B teams, or all the rest of it. Companies are doing it their own way, but this, I think, provides that together, and yeah, that's been useful. I don't know, Michael, if you've had any engagement with people in the last couple of days on this.
Yeah, I mean, I think the feedback that we're getting, Steve, is that a large proportion of our members were kind of ready, and we're already dealing quite effectively with social distancing in the workplace even before this guidance came out. So whilst the guidance is helpful and reassuring, in a sense, I think we were well placed as a sector to manage this far better than many other sectors. The issue that we're flagging on the right-hand side of this slide is that the challenge for us is more about actually getting back into the system and the system responding to that, rather than us managing the guidance and the distancing, isn't it? So there's this NIHR consultation, which is ongoing, as I understand it. We responded to some initial questions on it, and it's due out soon, I think.
Yeah, so I think that, in a sense, the big things for our companies are either running labs and managing your teams, which we've talked about in advance, and this working safely document, I hope, adds to the sum of understanding. The other thing is, of course, if you're running clinical trials and you need stuff to work with the NHS and particularly through NIHR, and that's been paused, there is thinking in government, and there is understanding from the information we've seen of the vital need to get this back up and going for patient benefit and for life science sector, so that we can hit the timeframes and the milestones. And there is a consultation on this, and we're expecting a restart plan. But I think also we can see that the challenge of getting the NHS back up and running, having pivoted so hard to support COVID, build the Nightingale hospitals, to get back up and running is a big task. I think they've got that research is an important part of that, and they are working on their own restart plan. We've not seen it come out yet, but I think we can see that is going to be a challenge. We've inputted, it's a priority for us. NIHR and NHS know it's a priority, but I think we need to be sanguine about how easy that is to switch the light on. It's not desperately easy. We hope to see some more stuff on this next week.
Okay, good stuff. Okay, well then time for another quick poll, Steve. I mean, so the government encouraged people to go back to work this week. I suppose the question is, are we seeing any differences yet? So here's the second question. Do you want to read this out for me?
Yeah, so government recommended that people should return to work, those who can't work from home. In terms of your own organisation this week, have you seen any change since Wednesday, I suppose, is basically the question. Have you seen additional people physically going into the workplace as a result of the change? Nothing, no real change, or we don't know, not possible to change. So has there been a difference this week? And I'm happy for this to be also, whether you notice a difference in the bus or in the car park or anything else. I'm just interested in whether we think there has been change and in terms of the ways of work, or whether people are staying with where they've been.
Yeah, okay, good. We're up to our 2/3 level, so I think I shall close the poll in a second or so. Last votes. Okay, thanks very much for everyone for doing that. Let me just share the result with you, Steve. There you go.
So 13% have stayed at home, so don't know. 15% have seen a bit of an increase, but quite clear here, not many people have seen a real change in the last couple of days. So always interesting to get the feel of the sector. I still being based at home, it's hard for me to get a sense. So it doesn't feel like a change to the BIA. I hope we're continuing to provide value working virtually.
Okay, good stuff. Right, moving on to test, track and trace, Steve. kind of moves on this front, haven't there, in terms of the way government's organising itself, with Baroness Harding being given a role. What do you understand about how that's working?
Yeah, so I mean, if you think about it, last month we were all doing it was all part of the Matt Hancock 100,000 challenge. We've got to get to 100,000 tests a day. How are we going to get to 100,000 tests a day? In the last week, we've seen Dido Harding appointed as a Supremo, a czar, to look across testing, tracking and tracing, the integration of the NHSX app, the testing capability and the tracing program. And I think really interestingly, bringing in players from Birmingham Women's and Children's Hospital, Sarah J. Marsh, and crucially local government in Tom O'Riordan, the CEO of Leeds City Council, to think about how you integrate that. So I think from our perspective, it's sort of another reorganisation of government, which means that there's a whole new set of people, and we're still finding our way through that as we speak. I think, you know, that this also then leads to a next iteration of if the aspiration is to go from 100,000 to 200,000, as the Prime Minister mentioned, in terms of capacity, what's that going to be used for, how that's going to be used, what's the logistics and how that's going to be organised, and crucially what technologies and what platforms are going to be used for that are the questions that's reopened by this. And you can see obviously a new portal for care homes to arrange coronavirus testing. I think for me, I'm slightly in a week where we've seen it change, but it's not been explained to industry very easily yet how this be laid out. And I don't know if Michael's a Wolves fan, where he's put the fact that the innovation here from many players in the private sector, including Wolves, the point here I think is that test, trace and track is not simply, well, test, trace and track will be part of the public health effort, but perhaps the usage of testing will diversify, and we are seeing employer-led initiatives, if you think of Wolves as an employer, to look after their small number of staff, if you like, their small team. It's interesting that we may see diversification in this as we go forward. I think that's why you put this one in, not because you're desperate.
Because I saw them sort of pioneering that kind of local level testing solution, which yeah, it seems to be kind of something that a number of people across industry are thinking about. Okay, final bit of news, Steve, just kind of latest stuff on the sort of the wider government policies, the kind of the support schemes, and this idea of quarantining, which is something that our industry has kind of flagged as a challenge to government, hasn't it?
Yeah, so furloughing has been important in the sector, and Chancellor has announced it's been extended by 4 months, so that there's going to be some flexibility. We'll see how that works out, but I think that's a welcome move, and people will be able to return to work part-time. So I think responding to calls for business for that. The self-employed scheme opened this week, and I think quite a lot of people have got into that. So that's actually now available. So that's open. It was interesting in terms of the idea that people who travel into the UK may need to do quarantine for 14 days. This is a big challenge for anybody who's got to get a bit of kit fixed, where, you know, somebody comes from Holland both with the bit of kit and the ability to fix their bit of kit. How's that going to work is sort of our challenge. There's obviously exceptions for France, but that's not everybody else, and there's quite a lot of challenge about this in our sector. So government are aware, and I think that the lines of communication are open. We've not got the answers we want yet, but thank you for your input on this one. We're on it, and we realise that this is a challenge for how many businesses run, and we've been very clear with government that it's not just car manufacturers, it's actually quite a lot of things in life sciences that need specialist support and specialist engineers moving around along with bits of kit.
I mean, I raised this directly with colleagues in OLS, Stephen. I think we've had a kind of a tentatively positive response on this, about the idea that our sector will get some sort of exemption from this, but still wait and see on that, I think. Okay, good stuff. A quick question on that, Steve, which has just come in. Why the exception for France in terms of the quarantining? What's the logic or the science behind that? Sorry, that's a tough question.
I can't argue it. I can't give you an argument from a science perspective. I can give you an argument from a Brexit perspective, which is, if you're going to keep the Pas-de-Calais and Dover-Calais going, you really do need not to have any delays on that border. Perhaps for the French, they're hoping that we'll enjoy summer holidays in France, And I imagine from a UK government perspective, the attraction of ensuring that there is not a bottleneck at the Pas de Calais, the Dover-Calais short straits crossing is significant, although it's interesting to see that there's already legal challenge on that from others.
Yeah, that's right, absolutely. You're clearly thinking about this in a big way, certainly in relation to the tourism industry, I've seen as well. So a quick question. So thanks, Paul, for your question on that. Another question we got in here is the same question we get every week, is how many people are voting in these polls? It's about 100 people today, so thanks for taking part. Okay, right, thanks for the news update, Steve. I'm going to move us on now to our topic.
One thing, Michael, which I think we're all still waiting for. We're still looking for the Innovate UK announcement of the knowledge intensive package. We've written to the business secretary on that one, and I'm sad that that's not, that's the one that we're not able to talk about.
Yeah, absolutely. Yeah, that's another. Sorry, well done for spotting that, Richard Wardfield. Thank you for your question on that. Hopefully, news soon. Good. Right. Time to move on to the topic of innovation, adapting operations, new digital health development. So I'm going to bring in our special guests. First of all, Sharon Lam, who's a partner at MWE. But I mean, just to set this up, Sharon, I suppose a couple of things for me to start with. I mean, Steve referenced it earlier, this kind of challenge that the NHS is facing in terms of kind of getting anything close to getting back up to running sort of business as usual is clearly going to be a big issue. We saw overnight a sort of a draft submission coming in from the Health Foundation, King's Fund and Nuffield Trust, painting quite a stark picture about the challenges of that. But we've also seen, out of necessity, some changes to the sort of the appetite for an implementation of alternative ways of working, haven't we? So whilst it clearly is going to be a challenge to get back to normal, there's maybe a kind of some recognition that things are different now. So I was sort of struck by Chris Hobson from NHS Providers saying, his quote was, "We'll build on the innovations that we've developed over the last 2 months, like 6,000 patient consultations a day now being delivered online compared to 200 before the crisis." And then there was Nigel Edwards from the Nuffield Trust said, whilst there's no easy route back to the way things were before in the NHS. Well, I suppose my question is, he's talking about an easy route back to the way things were before, but perhaps we're not going back to the way things were before, at least in some respect. So my questions that I'd like to explore with both you and Nick are really, what is the future for innovative healthcare after COVID? What's different now? And what are the implications for some of the companies and organizations in our sector? Who stands to gain, who maybe stands to lose from this? So there's the kind of the setup. Hopefully that makes sense. So Sharon, you're a partner who specializes in healthcare at MWE, aren't you?
Yes.
So thanks for joining us. Digital healthcare certainly isn't new to you. I mean, we talked the other day about how you were involved in the launch of Babylon back in the day, kind of a few years ago. So in your sort of expert perspective, how likely do you think we are to see adoption of digital healthcare accelerate as one consequence of this pandemic?
Yeah, I mean, Chris Hobson is absolutely right to point to the adoption from 200 to 6,000 a day. I mean, that's absolutely staggering. Telemedicine and remote healthcare has been around for, well, I suppose in the terms of digital development, a long time. At least 2015, 16, it's been available. Primary care particularly, but particularly on kind of, it hasn't been adopted at scale in hospital settings. And if you think the estimates are about 8 million outpatient appointments a year, moving to 6,000 a day is such a significant take up. On the last estimates, most hospitals have had access to a new technology endorsed by NHSX, and that's kind of accelerated the take up. And also, I think we have to recognize that NHSX didn't, although they did have an endorsed solution that they purchased for a year, they also accepted that wider use could be, wider technologies could be used. So Skype, Zoom could be adopted. And I mean, that's, there have been a couple of reasons why telemedicine hasn't been adopted full scale before. Some of that on the primary care level has been about the impact financially on CCGs, where although primary care is commissioned nationally through NHS England, through co-commissioning, it has separate budgets. And so the issue is, if one local area takes on a telemedicine solution, you could have a huge influx of patients into a particular area, having impact across the system as a whole. So that has been a barrier. And then, of course, we've also had resistance from clinicians. So even though we've moved to 6,000 a day, I've seen some statements from some of the professional bodies saying, oh, it can't be safe for some services. But I think no one can argue with the level of take-up and also the ease for patients. I think just coming back to a point you mentioned right at the beginning, and Steve mentioned it too, I think the question is, if we accept that we've all moved on and we're all using Zoom and Microsoft Teams and webinars to communicate, and this is the new way, and we're doing it in our social lives too. I mean, we're connecting with our own families. Our adoption personally of technology has just been so rapid. It's difficult to see how you can't really look at that in isolation against the kind of backlog of care that just the 3 months has caused. So as of yesterday, I think the estimate on waiting time for non-urgent care stands at 7 million patients. And by the time, assuming we're almost through the peak, we estimate there'll be at least 10 million patients. So that's with some elective care starting. And the other issue is that the kind of actual hospital flow is going to be hugely impacted. So the impact on efficiency for the donning and kind of removing of PPE, changing. And we spoke at the beginning here about, how are you going to implement it in your own workplace? Can you imagine that in a hospital setting? So these are factors that even when we go back to normal, there's going to be issues on trials, and the impact on the life sciences industry is not just going to be how do we adopt technology, but how do hospitals deal with that backlog in a way that allows for patients to access care, but for business as normal for life sciences to commence.
Yeah, absolutely. Okay, good stuff. Well, one of the things that I've noticed over the last few weeks is just kind of people kind of pushing the opportunity for new technology more broadly. One of our member companies, Precision Life, put out a release that I flagged on our microsite a few days ago about the use of its AI platform to select potential candidates to treat sepsis in COVID-19 patients. So, I mean, we talk about kind of the potential changes that might come about as a result of, people being forced to work in different ways. Is the use of AI likely to increase as a result of what we're seeing at the moment?
Yeah, I think that's a really interesting question. It looks from the technologies that we've been working on with clients and more widely across the system that there are probably 3 areas that have really been adopted for COVID and coronavirus, and that's probably the first one, and one that's had the most use is the one on the monitoring. So using data to analyze where outbreaks are likely to occur. I think that's been moving. That's not really AI in the healthcare setting that we would typically use it, so the kind of diagnosis tools. There has also been AI used, as you probably know, on clinical investigations and trials, largely on using it to kind of predict potential responses of the virus and to identify inhibitors. I think that's certainly helpful. And there have also been kind of increased use of, or kind of, may I say, mooted use of AI, because I don't think it's got there, about using AI to assess the likelihood that particular demographics or people with comorbidities would develop into more serious conditions. So to help with kind of access to treatment, questions about kind of scarcity of treatment if that were an issue. I think the reality with AI, which of course all of these technologies come down, if you're going to use AI in a diagnostics tool as a medical device, actually some of the research and the data that's required for that is still quite burdensome, and well, not burdensome, it's rightly burdensome. We want these things to be safe. Patients and the public have a natural skepticism about AI being used in these settings. So yes, I hope so. Certainly, we can see that there have been really good use cases. I was really encouraged, but I'm not, you know, given all that needs to go on to a technology, the device, at the moment, kind of going through the kind of devices registration, the testing, have we used adequate data? How is the technology going to be verified if it uses continual learning? I mean, these are still questions that I think remain. And one thing that's interesting that may impact it, of course, is the delay on the new medical device regulation. Because as it stands, our medical device legislation now is a lot more forgiving and slightly easier. And so if that's been delayed by a year, for those innovators looking to develop AI as a technology, which would be a device, certainly it would be an opportunity now to start and to get your class 1, that for to be grandfathered across if you can. Certainly the MDR would have introduced upclassing and significantly more, you know, kind of more difficult kind of processes to reach certification. And on that, the current definition of a medical device for software is expanded in the medical device regulation to include particularly monitoring. So although those things are probably within the existing law, there is an opportunity now for people to take advantage of that delay, I think.
Yeah, absolutely. Okay, good. I'm just going to move back one question. There's a question coming from Sam Samaratunga here about primary care use of technology, Sharon. I don't know whether you know the answer to this. Is the video consultation technology that's being used in primary care the same technology? I think that means the same across the system, or are multiple systems being deployed across different CCGs? Do you know?
I think there are multiple solutions being adopted. I mean, clearly there are 3 or 4 that are front runners. So, you know, those have definitely, you know, you've already mentioned some of them, but there are many others. NHSX endorsed Attend Anywhere, and that probably sped up some of the acceptance of the technology. The other thing that was helpful, I think, on this, for primary care, but particularly for hospital outpatient appointments, was that there was a clear recommendation and encouragement. So NHSX and NHS Digital issued a statement saying, we actively encourage the use of video conferencing to carry out consultations with patients and service users. So in primary care, they don't have the statistics as they have had, the stats that Chris Hobson referred to and that I did. It's just April 200 to 6,000. But the estimate is that most of primary care has moved to a telemedicine model.
Yeah, absolutely. Okay, good stuff. Look, in the interest of time, I think I'm just going to turn to Nick quickly, but I might come back to you, Sharon, because I think we're going to have a bit of overlap in terms of comment on this question that I've got about kind of data sharing. But Nick, just to bring you in, if I can. So Nick, you're in charge, executive chairman at RSA Group, so you're so well connected across the sector. You're presumably talking to a lot of people all the time, but I know you're also a non-exec in some biotechs as well. So really useful to have your perspective on this issue, on these issues. So I suppose kind of, you know, first question is, you know, thinking about how things have panned out across the pandemic so far, what are you sort of picking up as the kind of the big implications, the big impact so far on what's happening?
Well, there are the obvious changes in the interaction between the industry and healthcare systems and patients. So, and the impacts of shutdown. So if you kind of go through the life cycle of the industry, preclinical research has been closed down as labs have been closed down, but I see that coming back quite quickly. And in clinical research, anything that isn't a COVID trial has stopped. There's no access to patients. There's no way you can go into a hospital setting or get drugs in a primary setting to people. Face-to-face interaction with commercial organizations and healthcare systems and regulators has, again, dropped enormously. though there are some really promising changes in behaviour from the regulators in that they're engaging much better and much more speedily in all aspects if people bring a good case to them. Supply chain, I think, has stood up brilliantly to the challenge here. They're the one group of people who have become really busy, and that's across drugs, diagnostics, devices, and even in digital health. What you see there, I think, is a positive impact of some of the Brexit preparations. I think things would have been much worse in the UK if we hadn't already started stockpiling some of the things that we found we need here. You see specific problems in generic medicine where demand has shot up primarily through patients being prescribed larger volumes of medicine to tide them over to make sure they have to go less frequently to the pharmacy or to the doctor. Most of those generics organizations have been fabulous about not putting their prices up. They're having real problems with air freight and getting product in from other places, and in the pipeline there's an enormous issue, I think, building because the API production has been focused globally in two countries, India and China, and that's going to hit both the generic and the ethical industry. That's a serious issue to come. Those shutdowns, slowdowns mean that access to medicines as we come out of this might actually be worse than while we're going through it. In digital medicine, my friends in digital medicine, from the very largest companies to medium and smaller companies, have said that they've had 10 years worth of uptake in 8 weeks.
Wow.
And I personally think that, combined with a couple of other facets of what's going on here, really promises well for the future of healthcare. Again, especially in the UK, there's been a historical aversion to healthcare systems interacting with commercial systems because they're for profit. There's nothing like a pandemic to focus the mind, I think, is what we've discovered here. The last one that was anything even close to this was HIV, and that was a slower burn and a much larger profit opportunity. And certainly less much more discriminating, if you like, in terms of the populations who are hit. What that's done, that focus has reduced internecine squabbling within health systems, within hospitals, between hospitals, charities, and other academic institutions. It's remarkable how a purpose drives collaboration, and when we can't see each other face to face, these digital platforms, from the just the teams up to those remarkable new AI insight driven blind giants, if you like, has been astonishing. So the uptake has been astonishing. It is a lack of an alternative. Will it persist? Well, I believe it can. And if we get the regulators engaging more closely with companies who trust each other more, where clinicians understand that, and then if you add to that the really big message, the take home here, which beds into informatics, is diagnostics. Everybody knows we need a diagnostic. Is the only way that we are going to get the world moving again is with rapid, reliable, low-cost, scaled diagnostics. That requires information flows and personal information flows between me, my healthcare system, Singapore Airlines, and whoever I want to see face to face. And in the absence of a totalitarian system like China, where it appears on your mobile phone, we have to learn to trust each other with that. So I think all of those facets together, if we can find a way to maintain them out of this crisis and expand them into the world of drug discovery, drug diagnostics, and stratification through trials and preclinical work, if we can bring all of that together, we can start making data-driven decisions and start receiving data and insights back from patients. Where that leads us in the kind of logical end step is to outcomes-based medicines and payments. And as a patient, we all have to support that. We want to pay to be well or not to be ill. We don't want to pay for interventions. Healthcare systems don't want it. it's arguable whether in the US and other insurance-based systems, whether the systems and the doctors' interests are aligned as well as ours are. So this is an opportunity for the UK to step forward and for UK-based ecosystem to bring more to it. I've got one more thing to say on that, which is you can add the other elements that the ecosystem's been trying to bring forwards, the 2 million genome project, the biobank projects, the catalysts. All of those things actually give us a real opportunity to make this stick for the benefits of patients. I'll shut up now.
Well, no, I mean, it's a really interesting point. Just Sharon, coming back to you on that point, I mean, I hear that the ONS, Office of National Statistics, are looking ultimately to recruit, was it 300,000 people into this prevalence testing kind of program. We know on the Isle of Wight that there's been actually quite positive uptake of the NHS app. So I mean, in many ways, it looks like we could have access to large amounts of data and greater availability of data. But I mean, what about these concerns people have about data sharing and privacy? You know, from a kind of a legal perspective, what's the position on collecting and sharing this kind of data? What are the kind of the pitfalls, the things that we have to watch out for? And is the existing legal framework kind of fit for purpose on this?
Well, that's a series of really big questions there. I think the data law position on the collecting and on the contact tracing app in particular is not exactly straightforward, particularly where you probably know there are two types of contact tracing app. One is centralized, which is the one that is being looked at on the Isle of Wight. So effectively, contact tracing, for those who don't know, is kind of a connection between your Bluetooth phone. You download the app. The two phones can relay their signals through continuously changing keys. And that information can either be kept on the phone so that when someone registers that they've been, you know, they're unwell, they've been diagnosed, it then sends the signals to the other phones, or it can be held through a central database. So most countries are looking at some form, Western countries are looking at some form of decentralized app where that information is not collated centrally. At the moment, it looks like the UK started on a centralized app moving to a decentralized server. Now, the difficulty with the centralized server is the question about what that data might be used for subsequent purposes and how secure it is, etc. And the UK government's rightly said, of course, that apps like this are kind of prone or can be prone to sabotage. So how do you know if somebody, you know, if I say I'm been tested positive for COVID, how do you know that how do you verify that diagnosis? So that it requires some kind of processing back to a centrally held database. And likewise, how do you know that that doesn't link properly to the next person's care records? How does that person, the second person, get informed? And that does raise some quite significant questions under GDPR, not probably to be answered in the remaining time, because I could probably spend another hour or so on that. But it's interesting that there's been a slightly harder view taken by the Data Protection Supervisory Board on its opinion on the data usage, requiring consent, requiring strict compliance with GDPR, requiring strict use only for that purpose and not for any wider purpose. So I think there were some questions about whether that data could have been used for wider research and wider kind of technology. I think that probably would have to be clearly consented and continuously consented, which obviously raises some questions. I mean, clearly we've taken some, for the period of COVID though, the UK has taken some pretty kind of permissive views to the sharing of data. So forgetting about GDPR for a moment, obviously we have a dual regime, confidential information and GDPR, Data Protection Act. And at the beginning of April, we had the issue of the revised regulations effectively lifting confidential information for the purposes of COVID. And then those were supplemented by notices to a whole range of healthcare organizations actually requiring them to share that information for the purposes of COVID. So the purposes are widely defined, and the number of people to whom those notices were addressed was widely defined. And that's given some rise to some questions about where is that information going to be used? Is it being safely used? I think there's a balance here, isn't there, about are we moving to a point, as Nick has said, that we move to a different landscape where data donation, my data as a patient, my information as a data subject, where I'm happy for that to be donated in a sense for the public good. Now that in this context, I think we have a real opportunity to have a proper discussion about what information is required for clinical research and investigations and why that benefits other people in a way that you don't have outside of a pandemic. So what I hope is that the concerns are properly addressed, those that have been raised, so that we don't lose the opportunity and that it becomes an idea of everybody's collective information is helpful for drug development.
Yeah, absolutely. So Nick, I mean, let's assume that there is more data available, at least in the short term. How can we maximize the opportunity? I mean, one thought that strikes me is, maybe what we're seeing is actually patients and the public are actually more willing than we thought. Are we being a bit too cautious, perhaps, in terms of the sort of the provider and the industry view? What do you think?
I think that's the default position for regulators and governments, is that they have to be cautious. So yes, of course they do, and they have to cover all kinds of malfeasance where the general population are happy every day. My bank knows where I am, Google know where I am, Facebook knows where I am. They probably all know my pulse rate, how much I've spent in the last week, and they're very happy to do that for pure commercial advantage. So logically, sharing my health data, whether that's anonymized, pseudonymized, or just direct, is with a system that exists for my benefit. I don't understand the problem. I assume that everybody knows everything about me now, and I'm happy to do that. I think arguments like they might put up my health insurance or use that are valid, but these are technical problems, not legislative ones. And the more complex you make the legislation, the more easy it is for people who are cleverer than you to navigate those, and the less easy it is for people to use that data for collaborative, large-scale, beneficial projects. So there has to be a sea change with this. Personally, I think there's an answer in blockchain technology. I would like to see, especially in the UK, I would like to see a system where the NHS was allowed to access everybody's data. That was part of the payment for free healthcare at the point of delivery. I think you could blockchain that so that you could then say, if there was a financial benefit, if there was an IP created or a product created that had commercial value, that you could have micropayments back to you, or even better, that you could choose to assign those to a cause that was important to you. And this is all technically tractable today. We could say, yes, I will use my data, and cancer is important to me and my family, so any commercial upside from this, I would like to go to Cancer Research UK or to another charity, or I'm happy for that to circle back into the NHS, or no, I'd like it in my pocket, please. I don't understand why we are happy to give our data free to people who use it for the purposes of taking money from us, when we seem to be disturbed about giving it to other organisations who are trying to help.
Okay, good stuff. Thanks, Nick. Steve, you're back on camera. I mean, what's your take on all of that? I mean, big opportunities, but maybe some notes of caution as well.
Yeah, I mean, I think the key thing is the point as to how fast the world has changed, particularly in primary care. And if you think that the real change here is amongst a population, probably an elderly population that wasn't as au fait with some of the technology as some of the digital natives. The fact that my dad is now complaining that they're not offering Zooms at his surgery is the key factor. He's gone from being a user of Zoom in 6 weeks to an advocate on the health system to use this. And I think, you know, my nan, who's now 94, wants to do things on Zoom. So I think that's the big change. The other change that nobody's talking about is the fact that the way that money works in the NHS has all changed. A lot of the debt has been cancelled in the NHS itself. So therefore, we've had a big reorganisation of the health service without anybody really noticing it in terms of money flows. And the question is, would you construct the money flows to go back in exactly the same way as they were under CCGs and hospitals, given where we are now, given the likely change in usage? I think that is going to be one that it's a dog that's not barking, but it's actually really, really important as to how you underpin and underwire the reforms that will go forward. And the other aspect is, of course, workforce change. So you've now got a lot of GPs who are working in a very different way, a lot of allied health professionals who are working in a different way, a lot of nurses, a lot of specialists who are working in a different way. They're able to do things far more efficiently. Perhaps they're enjoying the job again a bit more, and they're not having to schlep to places. It also means that you can move people around virtually a bit more easily. You know, you can do shifts now in a number of different places without having to physically move, and that may lead to changes in thinking about workforce, which is obviously one of the other things that's big to change. The other thing that's happened for many people in the health service is they've changed their job role. Many people were put into intensive care, and they may now think they may want to stay in that area, or more likely they're likely to reflect on their own training. We've seen people who come out of the last year of training go into roles in a sense a year early, nurses and junior doctors. Does that have implications for how clinical training is developed? I think it probably will have. So I think the sort of idea that we've seen 10 years of uptake in 8 weeks is the important one, and this will have implications all the way across the piece. And that's really the business opportunity. I think the point that Nick made that you know, we can demonstrate, I think, from the private sector, the agility and the utility that being part of either the increase in testing, new thinkings in the way clinical trials are being developed, or new solutions in COVID-19, it can be part of the solution. And hopefully, the key thing there is to maintain that that goodwill both for the UK and the global market.
Okay, good stuff. Steve, just a couple of questions, perhaps, well, maybe to any or all of our guests and you. Just firstly, back to the point that you made, Nick, about supply chain situations. So, I mean, we've seen the UK banning some export of certain drugs, haven't we? The question here from Naji Raymond is, if the supply chains are working so well, then how come we're still having to ban exports on certain products or APIs? Steve, you may want to comment on that, because I know you've been talking to Steve Oldfield at Department of Health as well on the supply chain issue. Any views on that?
I'll take a first crack at it. I think that because there is good insight from the NHS centrally into managing the supply chain for the NHS, they can see where things are moving differentially, and perhaps are able to take more preemptive measures to prevent things from going awry before things would go awry. So improved insight, largely built from on the no-deal Brexit planning, plus strange usage, if you want, in simple terms, lots of respiratory, lots of ITU, some palliative care use, is likely to lead to earlier interventions. I think Nick's point that we may not yet have seen the implications of shutdowns in China and India earlier in the year, even if they're coming back on, come through the system, is a really important one, and that's something that we're working with colleagues across the sector on.
Yeah, absolutely. Okay, sorry, this is going to dance around in terms of topics. Second question, Ian Davis is mentioning the point about the kind of the ethics of data sharing, especially within a kind of a blockchain environment. So his question is, as a comment, the big data companies that take money from us are the same companies that supposedly want to use big data for health. And these are the same organizations that gave data to Cambridge Analytica for the Brexit vote purpose. Najib also made this point. So, you know, what do we think about the ethical considerations of sharing data? Maybe that's a challenge back to the point you were making, Nick, about the opportunity here. There are safeguards as well. I don't know if the legal considerations here as well.
Well, if you're asking me the question, my answer to that is they knew that when they were giving Cambridge Analytica the data, they were doing something wrong. They thought they could get away with it. Yeah. So there will be bad actors, and when bad actors are discovered, they should be punished appropriately. The answer on the blockchain piece is you don't need the data to travel with the blockchain. You need the fact that the data existed to travel on the blockchain. So you don't actually, as long as you've got a safe central repository for that data, the audit chain can remain and not expose you to a plethora of new hacking opportunities. That's sort of the point of blockchain. So.
Yeah, Sharon, go on.
Yeah, and an opportunity perhaps, I mean, on blockchain is not, is also on the kind of active consenting. So using blockchain as a continuing consenting tool. So I think the difficulty comes because the data isn't used in a transparent way. And once you've clicked the box, yes, I'm happy to share it with X organizations, although technically you're required, the organization controller is meant to tell you who those organizations are, and many do. You don't ultimately know where it then gets used. But the opportunity on blockchain and some of the technologies would be allow you to actively keep a handle on where it was going and what it was used for, so that you were notified your data is about to be shared. Are you happy for it? This is what it's going to be used for. And so I think there's a real opportunity there that hasn't really properly been put into practice. I mean, it's there in theory. There are organizations with active consenting tools, but I think perhaps this is the technology hasn't caught up with kind of general usage. On your point about the big technology companies, I mean, I think there's a real there is a real question, though, isn't there, about the level of investment, the financial investment required on these platforms to properly utilize it. And there needs to be a better conversation about the amount of money and financial investment required to do so, and who takes the benefit from that. It may be that health authorities, hospitals are not necessarily best placed in terms of infrastructure and technology to develop those platforms, and actually require a proper partnership with technology and big platforms. I think at the moment it's a quite polarized discussion, not between us, obviously, we're all aligned, I'm sure, but it does seem that the argument plays out in the press in quite a polarized way, not recognizing how much investment is needed to make these things properly safe and effective.
Okay, good stuff. Look, we're unfortunately we're out of time. I mean, I feel like this could be a whole subject of a whole new webinar. Maybe our events team will book one in at some point soon. But Steve, just to finish off, I'm just going to turn back to you just to talk about what else is coming up, if I may. So as ever, we finish these webinars with just kind of more engagement opportunities, don't we? So do you want to just quickly run through these for us?
Yeah, so we're hopeful that the government industry webinar next week with all the trade associations will be out next week. We're hoping to get something on the therapeutics task force. That's what we've been promised. So if you're interested in therapeutics, we hope to be able to do that. Our weekly bulletin on a Monday, newscast provides hopefully an update in written form, and that's going on. And our microsite is where we put all the latest information if you're not there. So if you're not on a webinar, so do please have a look at those. And if you've got ideas for future webinars, do please give them to us, and comments and queries to biaevents@bioindustry.org.
Brilliant. Okay. I mean, on that point about feedback, yeah, I mean, when you get the feedback survey after this webinar closes, do please let us know, and we'll try and pick up some of the extra questions that we haven't been able to talk about because we've run out of time. Final slide for you, Steve.
Yeah, if you don't know the BIA very well, or you're keen to know more about us, do please engage with us further. We do lots beyond COVID, lots of opportunities to engage in our advisory committees or connect with other people in the sector, grow networks for yourselves through leading events and expert committees. We've got a savings program as well as making sure our members' voice is heard in Whitehall, Westminster, Europe and global fora. So if you'd like to know more, do please contact Michael. With that, thank you very much.
Okay, brilliant. So thanks again to our special guests, Nick Stevens, RSA, Sharon from MW. Fantastic contributions, both of you. Really grateful. And see you all very soon.
Thank you.
Thank you very much. Bye-bye.